welcome. This presentation will focus on intimate partner violence, clinical insights, and trauma-informed interventions. Intimate partner violence, IPV, refers to any behavior within an intimate relationship that causes physical, psychological, or sexual harm to those in the relationship. This can include acts of physical aggression, sexual force, psychological abuse, and controlling behaviors. IPV is not limited to heterosexual couples or a specific gender. It affects individuals across all races, ages, sexual orientations, and socioeconomic statuses. The CDC reports that approximately 1 in 4 women and 1 in 10 men have experienced IPV in their lifetime. This underscores the widespread nature of IPV and highlights the importance of early intervention and comprehensive support. The objectives for this presentation are as follows. First, you will learn to define IPV and recognize the various forms it takes. Second, we will examine how IPV impacts mental and physical health, drawing from clinical evidence and survivor experiences. Third, you will gain insight into trauma-informed care practices specifically tailored to IPV survivors. Lastly, we will explore how cultural identity and social systems influence survivor experiences, helping clinicians deliver sensitive and equitable support. These goals are rooted in Bloom's taxonomy, aiming for both cognitive understanding and applied clinical skill. IPV is a complex matter that can show up in many ways. Although physical abuse is easy to see, emotional, psychological, financial, and digital abuse can have just as significant consequences. A person's self-esteem can slowly wear down because of emotional abuse. While money control can cause survivors to be stuck in unsafe positions, intimidating someone with their location or sending scary messages is now a common form of abuse. Understanding all types of IPV allows clinicians to detect damage that does not involve physical injuries but is still very impactful. IPV can create problems that continue for a long period. Those who survive cannot escape the high risk of PTSD, depression, emotional and substance-related disorders. They may face ongoing diseases such as migraines, stomach problems, and sleep difficulties. Being exposed to trauma over time can affect the brain's chemicals and the person's way of feeling and thinking. When diagnosing and deciding on treatment, clinicians should factor in the effects these factors may have. Some people may only report body-related pain, hiding the trauma they went through, which is why it's essential to look at care through a trauma-informed approach, according to Black 2011. Many people ask, why don't they just leave? The reality is complex. Survivors often form emotional bonds with their abusers, known as trauma bonds. Financial dependency, fear of homelessness, or retaliation can keep someone trapped. Cultural values and religious beliefs may discourage separation. Survivors with children may fear losing custody or disrupting their children's lives. These barriers highlight the importance of providing patient, non-judgmental, and resource-focused support to empower survivors on their own timelines. IPV affects everyone, but some communities face unique risks and systematic barriers to help. LGBTQ+ individuals may not be believed or may lack safe shelters. Immigrants might avoid seeking help due to fear of deportation or language difficulties. People of color may face systematic biases within the legal and healthcare systems. Culturally competent care is essential. Clinicians must remain aware of how privilege and oppression intersect with trauma and tailor their support to meet each client's unique needs. Trauma-informed care starts with understanding how trauma affects individuals and incorporates that knowledge into all aspects of service delivery. It means prioritizing safety, both physical and psychological. Building trust involves being honest, consistent, and respectful. Empowerment comes through offering choices and validating a survivor's experiences. Clinicians should adopt a strength based approach that honors each person's autonomy. Cultural humility is also vital. It means being open to learning about others' experiences and perspectives. Routine screening can help identify IPV early. The HITS tool, Danger Assessment, and AAS are brief, validated tools that can be used in clinical settings. However, they must be administered privately and with attention to confidentiality. Never screen a patient when their partner is present. Also, be prepared for disclosure and know how to respond supportively. Documentation should be clear, factual, and avoid victim blaming language. Screening is a first step and must be followed by appropriate support and referrals. Effective intervention requires both clinical expertise and collaboration. Therapies like CBT and EMDR can help survivors process trauma. Equally important are community supports, legal aid for protection orders, shelters for safety, and case managers for long term recovery. Every safety plan should be unique and continually updated. Remember, our role is to empower, not to make decisions for clients. Continuality of care, following up, coordinating services, and being a consistent presence is crucial for building trust and support healing, as per Centers for Disease Control and Prevention 2021. In conclusion, IPV is a serious issue with far reaching consequences. As clinicians, we are in a unique position to provide critical support that can lead to safety and recovery. A trauma informed and culturally responsive approach is essential. Use the resources provided here, including the National Domestic Violence Hotline and local services. Thank you for your commitment to learning more about IPV and for being part of a network that supports survivors on their journey towards healing.